So there are three major factors that affect the stroke volume of the heart, and they are the heart's preload, contractility, and the heart's afterload. And we'll discuss the three of these now. The first of these factors that we'll discuss is the preload. Preload can be described as the degree of stretch that is felt by the ventricles during ventricular diastole. As the ventricles are relaxing, the atria are contracting and pushing blood into the ventricles, and this naturally is going to fill up the ventricles. The more blood that's entering the ventricles, the greater the stretch is on the walls of the heart, and that stretch is the preload. The concept of preload can be compared to the stretching of a rubber band. The greater the stretch on the rubber band, the more forcefully that rubber band will snap back. So the more stretch there is on the muscle fibers in the ventricles, the more forceful the contraction of the ventricle will be, and that will in turn increase stroke volume. Normally, the more blood that is filling the heart during ventricular diastole, the more force of contraction there will be during ventricular systole. Preload is directly proportional to the end diastolic volume. The more volume that's in the ventricles at the end of diastole, the more stretch there's going to be on the walls of the ventricles, and therefore that's going to indicate that the preload will be larger. This relationship can be described as the Frank-Starling law of the heart. Now, since the preload is proportional to the end diastolic volume, we can look at the end diastolic volume and relate it back to how it's going to affect the stroke volume. I have just rewritten this formula here to show you how the end diastolic volume plays a role in stroke volume. Again, we saw this formula on the previous slide. So the end diastolic volume minus the end systolic volume gives us our stroke volume. The amount of blood in the ventricle at the end of diastole, or during ventricular relaxation, minus the amount of blood that is remaining in the ventricle after the ventricle has undergone systole, gives us the amount of blood that has left the ventricle and gone into the aorta. Now, the end diastolic volume is determined by two major factors. The first being the duration of ventricular diastole, and the second being the venous return. The longer the duration of the diastole of the ventricles, the more blood that's going to be allowed to move from the atria to the ventricles. The venous return is the amount of blood that is entering back into the right or the left ventricle, depending on which side of the heart you are using. So naturally, when there's an increase in heart rate, the duration of ventricular diastole is going to be a lot shorter. The shorter the duration of diastole, the less time there's going to be allowed for ventricular filling. And the less amount of time to allow for ventricular filling, the lower the end diastolic volume will end up being. If the duration of ventricular diastole doesn't last for a long enough time, the ventricles might end up contracting before they are adequately filled with blood. Now, the venous return is also a very important factor in the regulation of the stroke volume. The more blood that's returning back to the heart, the more blood that ends up in the ventricles. And the more blood that ends up in the ventricles, the greater the end diastolic volume. The second major factor that will help in the regulation of stroke volume is what's known as contractility. Contractility refers to the strength of the contraction of the myocardium. Put simply, the harder the contraction of the muscle fibers, the greater the force that will pump blood from the heart, and that is referring to the stroke volume. The contractility of the heart can be increased or decreased by certain substances, namely positive inotropic agents and negative inotropic agents. Any type of positive inotropic agent is going to increase the contractility of the myocardium. So naturally, we see this in the sympathetic nervous system. The sympathetic nervous system will dump norepinephrine on many of our body tissues, including the heart. And when norepinephrine is dumped onto the heart, that's going to significantly increase its activity. Certain hormones, such as epinephrine and thyroxine, or tetraiodothyronine, also act as positive inotropes. And another positive inotrope is the presence of increased calcium concentrations in our cell's interstitial fluid. As we saw a few slides ago, Calcium is also going to play a very important role in the cardiac action potential. So the more calcium that is flowing into our cell during the cardiac action potential, the greater the next force of contraction will be. Now on the flip side, the negative inotropic agents are going to decrease contractility of the heart. All of these factors will decrease stroke volume. Increased potassium levels in the interstitial fluid are also going to prevent cardiac contraction. And calcium channel blockers, as the name of this class of drug would imply, is going to decrease the amount of calcium in the interstitial fluid. So that will also decrease contractility of our cardiac muscle. The last major factor that will aid in the regulation of stroke volume is the afterload. The afterload can be defined as the pressure in the large vessels that the ventricles must overcome in order to eject blood into them. So essentially, what's going on here is that as the ventricles are preparing to pump blood into the large vessels, specifically the aorta and the pulmonary trunk, there is a pressure in those large vessels. And in order for that blood to open up the semilunar valve and push into those large vessels, the pressure in the ventricles must exceed that of the pressure in the large vessels. Afterload can be looked at as a measure of resistance. This is one of the reasons why hypertension is such a damaging condition. Hypertension refers to high blood pressure and is also the first stage of heart failure. The greater the pressure in the vasculature, the harder it is for the ventricle to pump that blood against that high blood pressure. One other factor that can affect the afterload is atherosclerosis. Atherosclerosis refers to the narrowing of blood vessels due to the deposition of plaques on the inside of the vessels. This in turn will increase blood pressure, and increased blood pressure increases our afterload. So to relate this back to stroke volume, the greater the afterload, the harder the ventricles are going to have to pump in order to eject blood. The greater the pressure, the greater the end systolic volume. This is the volume after the ventricle has fully contracted. If there's a higher pressure that the ventricles are pushing against, it's naturally going to be much harder to pump blood against that, and more blood will end up staying in the ventricles as a result. And because less blood entered into the circulation, that therefore directly will decrease the stroke volume. Now we just spoke about three factors that affect stroke volume: preload, afterload, and contractility. But we have to remember another formula that even came before stroke volumes, and that is cardiac output. The formula for cardiac output is stroke volume times heart rate. And we've just spoken about stroke volume and what regulates it. But here on this slide, we're going to talk more about what's regulating heart rate. We have to include this information about heart rate, as this is also playing a major role in what our cardiac output is going to be. So based on the formula that we see, the greater the stroke volume and the greater the heart rate, the greater the cardiac output. So the heart rate is naturally set by our autorhythmic fibers. However, our heart rate can be heavily influenced by the effects of the autonomic nervous system. Both the sympathetic and parasympathetic nervous systems play a direct role on regulating heart rate. Sympathetic nerve fibers are going to increase heart rate, and parasympathetic nerve fibers are going to decrease heart rate. Just as we saw these factors affecting the stroke volume, they will also affect the heart rate as well. So hormones such as thyroxine and epinephrine will both increase heart rate. And again, the more heartbeats that we have occurring in 1 minute, the more the cardiac output will be. So an increased heart rate is referred to as tachycardia, and a decreased heart rate is defined as bradycardia. The limit for what's considered tachycardia is greater than or equal to 100 beats per minute, and bradycardia can be defined as less than or equal to 60 beats per minute. Naturally, on average, we expect to see about 75 to 80 beats per minute. You can see that some other physical factors will also play a direct role on regulating our body's heart rate. Our age is one of the factors that will regulate this specifically. As we get older, our heart rate is naturally going to go down. Body temperature is one that you may have noticed. With increased heat comes increased heart rate, and with decreased heat comes decreased heart rate. As discussed on the last slide, The more exercise we undergo, this is going to stimulate our sympathetic nervous system, and that will also increase heart rate. Males and females are also going to have different average heart rates. Females tend to have a bit faster heart rates than males. And your activity is also going to play a big role in what your heart rate's going to be. Athletes will often have a much lower heart rate as their bodies are more adjusted to meet increased oxygen demands. So this will also affect what their tachycardia and bradycardia quantities should be. So let's put all of this information together on one slide to understand all of the factors that can affect our body's cardiac output. The first thing we want to keep in mind is that cardiac output can be defined as the stroke volume times heart rate. That is how we calculate the cardiac output. We take the stroke volume, which is the amount of blood that is ejected every beat, and multiply that by the amount of times that the heart is going to beat in 1 minute, and that gives us cardiac output. But you can see that many other factors affect what our stroke volume and heart rate are going to be. We first talked about stroke volume, so I will review these first. The three major factors that regulate our body's stroke volume are preload, contractility, and afterload. Preload is directly proportional to our body's end diastolic volume, the amount of blood that is in our ventricle at the end of diastole. So the more blood that is in our ventricle when it's relaxed and getting ready to pump blood into our major vessels, the greater the stretch on the wall of the heart will be, and therefore that will increase preload. As cardiac muscle fibers are stretched more and more, that's going to increase the force of contraction that they will exhibit. And the greater the force of contraction, the greater the stroke volume will be. Now, in terms of contractility, we can see that that's somewhat similar to what we saw going on with preload over here. The greater the contractility, the greater the force of contraction. And just as we saw with preload, the greater the force of contraction, the greater the stroke volume. So what is going to regulate our heart's contractility? It is both positive and negative inotropic agents that will play the major role in determining what our heart's contractility is going to be. Positive inotropic agents increase contractility, and negative inotropic agents are going to decrease contractility. A few examples of positive inotropic agents are our catecholamines, norepinephrine, and epinephrine, increased calcium in the extracellular fluid, as that will directly affect our cardiac action potential, thyroid hormones in the blood, or perhaps stimulation from the sympathetic nervous system. All of these will increase the contractility of our ventricles. And the greater the contractility, the greater the stroke volume. Now, lastly here is the afterload. Afterload can be defined as the resistance that our left ventricle needs to overcome in order to pump blood into the aorta. So the greater the afterload is, the more resistance there is, and therefore the less blood that's going to get pumped from the ventricles. Now, if afterload decreases, that will in turn increase stroke volume, because there will be less of a pressure for our left ventricle to pump against. So a decreased arterial blood pressure is going to end up decreasing afterload. Since there is less of a pressure to overcome, the semilunar valves are going to open much sooner and allow more blood to flow into our vasculature. So these are the three major factors that will affect our body's stroke volume. Increased stroke volume and increased heart rate lead to an increased cardiac output. Now, in terms of the heart rate, we'll see some other factors are going to play roles here. Chemicals such as hormones like catecholamines from the adrenal medulla or thyroid hormones from the thyroid gland are going to increase heart rate directly. Heart rate is naturally going to be regulated by our cardiac conduction system and the autorhythmic fibers that make it up. But the presence of different catecholamines in the bloodstream will therefore increase heart rate even more. The autonomic nervous system is also going to play a major role in regulating heart rate. The greater the sympathetic tone, the more increased the heart rate is going to be. And the greater the parasympathetic tone, the less the heart rate will be. And our other factors are based on age, body temperature, gender, and our general activity. The greater the body temperature, the more increased our heart rate is going to be. Younger individuals will have a higher heart rate on average, as well as females in general. All of these factors increase heart rate, which will in turn increase cardiac output. So a few imbalances that we will see that are related to heart activity are listed on this slide. We have hypo and hypercalcemia, we have hypernatremia, and we have hyper and hypokalemia. Hypocalcemia refers to low levels of calcium in the blood. Since calcium is necessary for the cardiac action potential, the lower the calcium levels, the lower the heart activity will be. And the exact opposite is with hypercalcemia. Hypercalcemia refers to increased calcium levels in the blood, and that is going to increase heart activity as well. Each of these two conditions will have an opposite response from each other. Hypernatremia refers to increased blood levels of sodium. Hypernatremia will prevent contraction by the blockage of calcium. Hyperkalemia and hypokalemia refer to increased and decreased levels of potassium that can be found in the blood. So hyperkalemia is increased potassium levels, and hypokalemia refers to low potassium levels. Now, potassium is important for repolarization. So if we have increased levels of potassium, that's going to prevent depolarization from taking place. If our heart cannot depolarize, that is called a heart block. Hypokalemia, referring to low potassium levels in the blood, can lead to irregular heartbeats, of which we call arrhythmias. So as you can see, the different levels of these different ions in the bloodstream will all play a major role on the activity of the heart.